Good afternoon, everyone. I am Dr. K. Saiteja. I am going to present a case titled When Immunity Blurs Vision, a case of post-rabies vaccination. 18-year-old boy who presented to us with a 1-week history of sudden diminution of vision and pain in the left eye, with the pain being aggravated on eye movements. There is no significant neurological or ocular history. However, the patient had a history of dog bite 29 days earlier, for which he took the rabies vaccine as per protocol. So symptoms notably began following 4th injection. So anterior segment examination of the right eye was normal. Visual activity of the left eye was 560 with grade 2 relative afferent pupillary defect in the left eye. Fundus examination of the right eye was normal. Left eye showing hyperemic disc with elevated margin suggestive of disc edema. And the fundus photograph of the left eye showing disc edema, and the optic disc OCT with RNFL thickness map showing thickening of inner retinal layers in the left eye. So my differentials were optic neuritis, NAION and CRVO. As NAION is unlikely, it typically occurs in elderly males, and CRVO is also unlikely as fundus findings doesn't correlate with CRVO. So I came to provisional diagnosis of left eye optic neuritis. So moving on to investigations, blood protein were within normal limits. Color vision was defective in the left eye and the contrast sensitivity is reduced. Serum antibodies like NMOSD, MOGAD, ANA profile were negative. MRI brain shows long segment thickening and post contrast enhancement, confirming the diagnosis of left optic neuritis. So the patient was treated with IV methylprednisolone 1 gram per day for 3 days, followed by oral steroids as per optic neuritis treatment trial. So post 15 days follow, visual acuity is improved to 6.6 with normal color vision and the contrast sensitivity. This is a follow-up fundus photograph showing resolution of disc edema in the left eye and the optic disc OCT showing thinning of inner retinal layers. So optic neuritis can be typical or atypical. Typical being most commonly associated with multiple sclerosis, which accounts for 5% of the cases in India. Atypical includes various etiologies like inflammatory, autoimmune, like NMOSD, MOGAD, metabolic causes, and rarely post-vaccination. MRA findings in multiple sclerosis will show short segment involvement. NMOSD will have chiasmal involvement, and MOGAD will show long segment and bilateral involvement most commonly. Steroids are the mainstay of treatment in the on optic neuritis, but atypical optic neuritis may require steroids along with immunosuppressants. So, vaccination-induced optic neuritis has been observed in the post-COVID era, but rabies-induced optic neuritis is extremely uncommon, and when unilateral presentation even more uncommon. So this is unique in my case. Probable mechanism could be autoimmunity or immune-mediated mechanical damage, or leads to blood-brain barrier, breakdown of blood-brain barrier. So to conclude, neurophthal examination should always start with simple torchlight assessment, and it shouldn't end with identifying the diagnosis. So etiology must be investigated further. Thank you.
Nice presentation. At presentation, when the patient presented to you, did you check for color vision?
Yes, ma'am.
What was the result?
Defective. Color vision was defective. Yes. Color vision is only basal plate he is reading.
Okay. Contrast sensitivity?
Reduced, ma'am.
And they were checked once the vision improved also?
Yes, ma'am.
Did you check for any vitreous cells?
No. Yes, ma'am. Is quite.
Okay.
Sharnitha is not there, no? Sharnitha is not there.